Orofacial clefts are one of the most common head and neck birth defects worldwide, and it affects children of all socioeconomics and cultural backgrounds, with a prevalence rate of roughly 1 in 700 live births. Clefts may involve the lip, alveolus, and palate in various combinations. Clefts are thought to be of multifactorial etiology due to genetic and environmental factors. Common conditions that occur in children with orofacial clefts include hearing difficulties, speech and language disorders, middle ear abnormalities, psychosocial issues, and dental abnormalities. Different dental conditions are usually associated with cleft lip and palate. Most of it are collapsed dental arches, malformed teeth, hypodontia, and supernumerary teeth. Alveolar bone grafting is an integral part of treating orofacial clefts and is considered as primary or secondary depending on the timing of the procedure. Usually, this procedure is done at the age of 6 to 12 years old. In addition, the need for orthodontic treatment is highly required in the overall treatment of the clefts, which involves expansion of the arches, comprehensive fixed orthodontic treatment, face mask therapy, and possible pre-surgical orthodontics in cases requiring orthognathic surgery. The complexity and extent of the orofacial cleft dictates a need toward an interdisciplinary approach where different medical and dental professionals are involved in the treatment. This case report describes a comprehensive dental treatment of a young adult male patient with a history of surgical repair of a unilateral cleft lip and palate with a severe upper and lower crowding and missing upper lateral incisor. It is now time to know our patient and also his case. A 17-year-old male patient presented with a chief complaint of unpleasant appearance of teeth. He had a history of unilateral cleft lip and palate on the left side. He had his lip repair done when he was still 2 months old, palatal closure at the age of 10 months, and lip revision when he was still 6 years old. Patient had a symmetrical face, straight profile, competent lips, and retreated upper lip with a scar on the left side. He had an average nasolabial angle, average lower anterior facial height with normal incisor shown during smiling. The upper dental midline was shifted 2 mm to the left, relatively to the facial midline. For the intraoral examination, it showed that the patient had generalized marginal gingivitis and the scar of the repaired cleft palate and alveolus in the upper left side with no signs of oronasal fistula. He also had generalized decalcification of the dentition. His CAS analysis showed that all permanent teeth were present up to the second molars, except for the upper left lateral incisor, which was congenitally missing. The upper arch was constricted anteriorly with 7 mm crowding, and omega-shaped lower arch with 16 mm of crowding. Here are the pre-treatment extraoral photographs. As you have noticed, that his chief complaint, which is the unpleasant appearance of teeth, is highly noticeable every time the patient smiles. Here are the photos of the patient's pre-treatment intraoral photographs and pre-treatment study cast model. As you have noticed, the patient's maxillary left lateral incisors is missing, and both of the arches suffers from severe crowding. As discussed a while ago, the upper arch was constricted anteriorly with 7 mm crowding, and the lower arch is described as omega-shaped with 16 mm of crowding. For the radiographic examination, the patient had normal morphology of the condylar head and neck with no apparent bony pathologies and normal maxillary sinus borders. All permanent teeth were present except for maxillary third molars and left lateral incisor. There was a bony defect in the area of the missing maxillary left lateral incisor, as shown in the photo. After taking the patient's cephalometric radiograph, It is discovered that the patient had skeletal class 1 relationship, average mandibular plane angle, normal lower facial height, retroclined and retruded upper and lower incisors, and retruded upper lip relatively to the E-line.
Collaboration. This treatment is a collaboration of different dental specialists, such as general dentistry, orthodontist, oral and maxillofacial surgeon, and periodontists. A collaborative treatment was done for the 17-year-old patient, which presented an interdisciplinary approach. To correct the presented case, soft tissue examination and several tooth restoration was done with the general dentist. Orthodontically, the patient received treatment for alignment and leveling to achieve correct occlusion. Oral surgeon was in charge with the tooth extraction process and alveolar bone grafting. And lastly, the patient was referred to a periodontist for an implant to replace the missing upper left lateral incisor. So now let's proceed with the different procedures and techniques. As this treatment has an interdisciplinary approach, the different dental specialists work alternatively to provide the best treatment as possible. The following slides present the different detailed dental procedures done by different dental specialists for the desired treatment plan. These steps include the following: extraction of maxillary first premolars, mandibular left second premolar, and the right first premolars. To properly visualize the final occlusion, the use of diagnostic casts was done, preceded with the start of orthodontic procedures such as the pre-edgewise appliance, Nitti archwires, and TAD. So as the space of the upper left lateral incisor was opened using open coil spring, ABG or alveolar bone grafting was performed using an iliac bone graft. And of course, continuation of molar and canine relationship and correction of tooth sizes discrepancy through composite buildup. Reaching the next step, patient was referred to the periodontist when a dental implant was placed with simultaneous bone grafting and absorbable membrane to correct the buccal bone concavity. After 4 months, the case was debonded with upper and lower S6 retainers for retention. Composite restorations of maxillary anterior teeth were done, and the final crown was cemented after 4-week period to allow the soft tissue healing. Finally, upper and lower wraparound removable retainers and lower fixed retainer from canine to canine were used for retention.
Results and outcomes. The post-treatment records shows that the treatment objectives were achieved. Extraorally, the case was finished with the ideal overbite and overjet, while the arches are well coordinated. As what we can see here in the intraoral radiograph and study model, it can be seen that the maxillary and mandibular dental midlines were coincident with the facial midlines. The Bolton's discrepancy was corrected, and the missing upper left lateral incisors was restored with the dental implants. In the panoramic radiograph, it can be seen that there is a radiolucency in the cleft lip area. However, the upper left central incisor was already restored using porcelain metal crown, and the lateral incisor was corrected using a dental implant respectively. The final cephalometric radiograph showed insignificant changes, except for the proclination of upper and lower incisors. The superimperfection shows mesial movement of the upper first molar of 4 mm, proclination of upper incisors, distal movement of lower first molar of 2 mm, and the proclination of the lower incisors. The inclusion of a diverse group of medical practitioners within the CLP team is crucial in order to attain optimal treatment outcomes. In this particular instance, the treatment team consisted of dental specialists from several disciplines. It is worth noting that all non-orthodontic medical issues were addressed prior to commencing orthodontic treatment. Additionally, it is important to highlight that the treatment center is a completely integrated cleft, lip, and palate team that is responsible for providing comprehensive care to the patient. The presence of maxillary deficiencies in a transverse dimension is frequently observed in individuals with a cleft palate. As such, expanding the maxillary arc is typically included as a crucial component of the overall treatment strategy for managing a unilateral cleft palate. In this case, it was observed that the maxillary arc did not exhibit any signs of constriction, and the utilization of the arcuate alone proved to be sufficient, rectifying the form of the maxillary arc. The optimal timing for implant placement following alveolar bone grafting remains a topic of debate among the academic community. In this particular instance, the dental implant was inserted following a time of 20 months. It was necessary to address the buccal bone defect by employing graft material. It is possible that reducing the interval between grafting and implant placement could potentially obviate the requirement for a subsequent grafting treatment. Over the past 2 decades, mini screws have been introduced to the field of orthodontics, and they have since been a widely utilized tool in various orthodontic treatment. Due to the patient's insufficient space resulting from the extraction of the lower second premolar, which only provided a relief of 16 mm, and the presence of significant asymmetry in the mandibular arc, where the right buccal segment protrudes further forward than the left, temporary anchorage device or TADs were employed. The purpose of utilizing TADs was to effectively manage anchorage during destabilization of the lower first molar and generate sufficient space to address the issues of crowding. The utilization of TADs enables orthodontists to effectively strategize and execute precise tooth displacement. The force exerted on the first molar was characterized by both distal and extrusive components due to the specific alignment of the wire extending from the mini screws and its interaction with the tooth. Following the debonding procedures, multiple upper Essex retainers were fabricated to maintain the achieved outcomes. The upper left central incisors, on the other hand, exhibited insufficient torque, which was subsequently rectified with the application of a porcelain metal crown. There were two potential solutions for the prosthetic repair of the absent tooth. In this case, the decision to choose for an implant was based on the implant's superior success rate and its ability to avoid negative impact on the neighboring teeth through the avoidance of the preparation procedures. After a period of 8 months, it has been determined that the results have remained consistent and unchanging.
The interdisciplinary treatment of an adult with a unilateral cleft lip and palate represents a comprehensive and holistic approach to addressing the complex challenge posed by this condition. Through the collaborative efforts of various medical and dental specialists, a tailored treatment plan is crafted to enhance both the physical and emotional well-being of the patient. The integration of surgical correction, orthodontic intervention, prosthodontic restoration, speech therapy, and psychosocial support forms the foundation of this approach. By combining the expertise of oral and maxillofacial surgeons, orthodontics, prosthodontists, speech therapists, and other professionals, the treatment aims to not only improve facial aesthetics but also optimize function abilities such as speech and chewing. Moreover, the interdisciplinary model recognizes the unique needs of each patient and emphasizes long-term follow-up to monitor progress and make necessary adjustments. The patient-centered approach fosters a supportive environment that acknowledges the emotional challenges associated with the condition and offers counseling and guidance to enhance self-esteem and overall quality of life. Ultimately, the success of interdisciplinary treatment lies in its ability to transform the lives of individuals with unilateral cleft lip and palate. By addressing the physical, functional, and emotional aspect of the condition, this collaborative approach empowers patients to achieve greater self-confidence, improve communication skills, and a higher quality of life. Through ongoing research, innovation, and compassionate care, the interdisciplinary treatment continues to evolve, offering hope and transformative results for those affected by this condition.